Let me try and record it again and see what, we are having a lot of technical issues. But oh, Yasmin is here as well.
Hey.
Hey, Yasmin.
Hello.
Don't worry, you've not missed anything. We've been in and out and out and in, and we are having a lot of difficulties with this thing. But anyway, right. So we were talking about, what were we talking about?
we were going on to the question. So we were looking at the answers of the quiz.
Yeah.
Quiz 7. Which of the following is the cause for dorsal dermal sinus?
Yeah, dorsal dermal sinus. So I was saying that dorsal dermal sinus, usually it is called a dorsal dermal sinus. And we were sort of like talking about that. Yep. Okay. So the first question here was, what is the primary pathology? What is the cause? Spina bifida does not cause a dorsal dermal sinus, and a dorsal dermal sinus can communicate from in between the vertebrae as well. So you don't necessarily have to have spina bifida. They can be associated with it or may not be associated with it. There is no herniation of the spinal cord because it's not a meningocele or myelomeningocele or anything. There is tethering, which is associated with it, but that is not the cause for it. And the cause is basically the fourth one, which is incomplete separation of superficial ectoderm from the neural ectoderm. Like I said, there are two, the spinal cord is surrounded by the ectoderm, and the skin is ectoderm as well. So there is this separates out, but if it sticks and the baby grows, it drags it down and forms a certain sinus between these two things. And because there is focal adhesions, a phylum from the spinal cord can then get attached to it, causing tethering of the spinal cord. And it may be associated with spina bifida, but those are not the causes of that. Obviously, spinal cord tumor, the epidermoids are associated with it, but not the cause for it. So the second question, dorsal dermal sinus is often associated with intraspinal dermoid or epidermoid. That is true. Again, that is not the cause, but an association. Differential diagnosis does not include, it can be a pilonidal sinus. You see a small dimple. You know what a pilonidal sinus is? It's also called Jeep driver's bottom.
Yeah.
Yeah, and it was very common in the Allied soldiers, Americans and British troops who were fighting in Far East, in Burma and in Malaysia and Indonesia and all those islands, because it was hot and sticky all the time. And when they were traveling long distances in their vehicles, in their jeeps, especially the jeep drivers who had this friction going on all the time, the hair follicles would grow inwards and cause a little pustule there. So that is called a pilonidal sinus. So on surface, it looks like a small dimple with discoloration and some tufts of hair. So that is probably the most important differential. Spina bifida is a differential, is not a differential because you don't see, sometimes, especially spina bifida occulta, there is no deformity on the skin or on the ultrasound. Sacral dimple is another one, and pseudosinus tract is another one which can present the same as dorsal dermal sinus. What is not a manifestation? It does have a small skin dimple and non-ostium. It does have angiomatous skin or some red bleeding sort of discoloration. it has hypertrichosis, which means increased hair on that, or hypertrichosis, or tuft of small hair. There is usually a midline or paramidline lumbosacral position, but it does not form a mass in there. Mass indicates either an abscess formation or infection, or a meningocele and a myelocele. That is why ultrasound is so important, to differentiate between these two.
And what do you mean by fluctuating mass?
A mass which, when you put your finger, it feels like a boil, or there's squishy fluid in it. That is called fluctuation.
Oh, okay, okay.
Okay, so if you have something and you put your finger and it,
and it kind of disappears.
Yeah, like
moves around.
Small fluid-containing mass. That is called a fluctuating mass.
Okay.
It shows fluctuation is a term used in medicine to define something which is soft, but you press it, it is soft. You take the pressure off, it retains its position.
I see. I gotcha. Thank you.
Primary treatment is basically you don't wait and see. It's not going to go away. You cannot wish it away. Physiotherapy to improve limb function would not help unless you have corrected it surgically. It is one of the management after the surgery, not a primary treatment. Antibiotics to control infection, you have to treat the cause of infection. If there is repeated infections and you keep on giving antibiotics, you are treating the infections, but they will keep on recurring. Surgical correction of sinus, yes, but mostly it has to be very aggressive treatment where the sinus tract is totally excised and the spinal malformation is corrected as well. So if there is a phylum, you have to cut that so that there is no more tethering and everything else. So those are the clinical sort of things you do with that. Let's talk about this brain ultrasound a bit. This is a kind of premature. It's 34 weeks. Now, the germinal matrix hemorrhage occurs anywhere before 35 weeks. So although it is nearing that 35-week mark, but still we regard this as premature. There's failure to thrive episodes of apnea and abnormal body posture, and babies sent for ultrasound. All premature infants these days are their brain ultrasound is done before the first week after birth, just as a precaution to rule out any intracranial hemorrhage, because the prognosis of survival of premature babies is how well you can support them if there is an intracranial hemorrhage, and how often fast you can place a shunt in. Because if you delay that, there will be more and more and more neural damage, and that then becomes the handicap becomes more bigger and bigger and harder to treat. Now in this one, there are this is a coronal through the anterior of the lateral ventricles, and you can see that there is this echogenic homogeneous structure in just infralateral to the anterior horns of the lateral ventricles. That is where your germinal matrix is. Now, what is germinal matrix? This is composed of developing neuroendothelial cells. So all these brain cells, they develop from germinal matrix, and then they migrate out. The neurons migrate out towards the surface to the brain cortex. So this, because it is rapidly dividing and very metabolically active, it obviously has to have a lot of blood supply to it. Simple rule of biology is the more active the metabolism, the more nutrition and oxygen demand, means more blood flow to that, which means more capillaries, which means these capillaries are very thin-walled, fenestrated, so they have these little gaps between their wall cells. So if there is any elevation of the pressure due to hypoxia, there would be a bleeding out. Okay, so and this germinal matrix is jelly-like. It's not a solid sort of substance there. So it is very easy to get a bleed in there. And this germinal matrix basically is very active between 22 and 35 weeks, and 32 weeks. It's very active. So any babies born before 32 weeks, 90% of them are at risk of developing germinal matrix hemorrhage. Between 32 and 35 weeks, it starts to involute. It has made all the neurons that needed to be made, and it then sort of like just cools down. It doesn't have to make any more neurons. And between 35 weeks onwards, it is almost completely resolved. So babies born after 35 weeks have very low chance of having the hemorrhage in this area. So the more premature a child, the more chances of germinal matrix hemorrhage. Okay, so on the right side, we have a very small little hemorrhage there, and it is sort of slightly extending into the ventricle, and the ventricle looks a little bit dilated. So there are four categories of this germinal matrix hemorrhage. We call the GMH1 as if there is only hemorrhage or this hyperechoic tissue in the germinal matrix. It does not extend into the ventricle, and it does not cause any dilatation of the ventricle as well. Okay, let me have this image up and share it with you. I think that would be a lot better so that you know what I'm talking about. Come on, here is the share here, this one. Okay, you can see the image?
Yep.
Yeah, okay. So I'm talking about the right side. Okay, so germinal matrix class 1 or germinal matrix hemorrhage 1 is when there is only a hemorrhage in the subependymal region and it does not extend anywhere. 2 is when it extends into the ventricle, like here. It is extending up into the ventricle. And if you have a central view, you may find a little bit of hemorrhage layering in the CSF of the ventricle. Category 3 is when there is dilatation of the ventricle or hydrocephalus as well. So whenever we have a germinal matrix hemorrhage, we measure the ventricular diameter. And if it is more than 3 millimeter, we call that hydrocephalus, so that becomes 3. And 4th one is when there is associated periparenchymal or periventricular leukomalacia or hemorrhage going on at the white matter surrounding the anterior horn. Okay, so number 1, if it is confined to a subependyma. 2, if it extends into the ventricle, 3 when the ventricle starts to enlarge, 4 when there is a periventricular hemorrhage seen. On this side, so on the right side, it is possibly type 3. And on the left side, there's a lot more bigger hematoma there. It is extending a lot into the ventricle. The ventricle is enlarged, but it is occupied by the blood. So you don't see it as prominent down the right side. And if you see here, just in the periventricular area, there is this diffuse hyper-echoic area seen in the white matter. So this is what we call periventricular leukomalacia or periventricular hemorrhage. Okay, and this is not an extension of this hemorrhage. This happens because all the veins that drain this area pass through the germinal matrix to be drained into the central vein. So when there is a hemorrhage and a hematoma here, that puts pressure on these veins, and these veins would then have back pressure and will cause a venous hemorrhage. Okay, so this is not an extension of the hemorrhage, but a venous hemorrhage due to constriction of the veins as they pass through the hematoma there. So on the left side, it is grade 4. On the right side is grade 3. Grade 4 has worse prognosis. 3 has better. 2 is better than that. 1 is better than that. So whenever you see, you're called in to do a brain ultrasound on a premature, this view is the one you take, and you have to show if there is any hemorrhage and to grade that as well. Because your prognosis and your management of the patient totally depends on this one image only and nothing else. Even if you don't do anything else in the brain, if you just take one coronal view of the germinal matrix, which is along the anterior horns of the lateral ventricles, you've done your job. Okay. So I mean, often these are very small, like, you can fit them in the palm of your hand. Premature 32-week, 34-week babies, and they are squirming, they are crying, there's a lot of emotions attached there. You are not really successful in doing a full brain protocol in these patients. Try to get this one image. And this is the image you should go straight in and take the very first, because then you have the key image. And even if you cannot do the rest of the brain protocol, it's okay. Okay, you have the diagnosis on this. But if you are following your protocol and you're doing your sagittals and then your coronals and then blah blah blah, by the time you reach to this image, the baby is impossible to scan anymore. So you miss the key image out totally. You can see it on the long or sagittal paramedian images as well. I will upload them with this thing. I will do it tonight so that you can appreciate that. But this one image is a lot more diagnostic than anything else. Okay. Yeah.
Good.
Okay, so yeah, I think we have gone way over time, but not anybody's fault. It's the technology's fault. Having issues. Anything you want to talk about or ask or discuss? I think we talked about a lot of stuff. Enzel, I'll give you the feedback on the case you sent me. Definitely, I will just have to find my reply, which I sent you back, and just forward it back to you. And I will look forward to your other assessment.
Thank you so much.
If you send it to me, even by Wednesday, I would be able to send it to you by Thursday. Yasmin, you have anything?
No, I'm all good.
Okay. Okay. Yasmin was my student how many years ago?
I graduated in 2009.
Well, there you go. I'm seeing her after 10 years.
Wow.
Yeah, she was in Wagga Wagga, and
Yeah, Wagga Wagga.
she's seen me in a very...
Where's that?
Yeah, country New South Wales.
Okay.
Yeah, and she has seen me in a very inebriated way.
Yeah, we all went to the pub when we finished.
Yeah, so that was it was all those boys who got me drunk with.
Yeah,
but
Adam and Ty, all those boys. Yeah.
Yeah, I called them my footy boys.
Ah, yes.
Yeah, and yeah, now I remember. I have seen your face, so now I remember you. But look, it was 10-year-old, and at my age, even if I remember, when I come into a room, what I'm here to do, if I remember that, it is a bonus. Don't expect me to remember things which happened 10 years back. Okay.
Can I ask one question?
Yes.
I just noticed, I mean, other people probably understand this, but when I sent, the format sometimes changes a bit, doesn't it? When you send things.
Yeah.
Does that work out when you receive it? Does it?
Yeah, but it does with the Word files.
Yeah.
And that is why don't push your images in the text.
Okay.
You write the text.
Yep.
And attach the images at the end of the document. Okay, and put the caption under that, figure 1, blah blah blah, so that when I'm reading and it says figure 1, if there is no figure 1 at that spot, I can go at the end and have a look at the figure. When you submit a paper to the journals, they always ask you to have your figures, your tables, your diagrams at the end of the paper, not in text, because like I said, like you said, things can change.
And is that how we should submit it as well?
Well, that's a good habit. It would be a lot better. When I'm doing my research subject, for the 4th years, for the grad diploma, I insist that they attach it at the end, but not at this stage, because look, content matters, not the presentation. If you're writing something rubbish in very beautiful things, and that is why I don't like word art and fancy fonts and colors people put in, and they think that they've written something very nice. They write rubbish in a beautiful way, doesn't get them marks. It's the content that matters. The other way to do that is to save your Word document as a PDF file.
Yes.
Because PDF then fixes everything at one place. So you can do that and then send as a PDF file. That would not change the format you have with that.
Okay.
I have to go. Thank you very much.
Okay.
Yeah, thank you.
Thank you.
Okay, well, thank you very much, girls. And Yasmin, you are here twice. One is Yasmin.
Yeah, I couldn't get it to work, so it was...
Yeah, we were having huge problems here. Technology here as well.
Oh, Ansel, so can I just ask, is anyone going to the ASA conference?
When is that?
It's soon.
June 20, 21, 22.
And where is it?
Brisbane.
No, I won't go.
I'm going. You're going?
I'm going. Yeah.
Okay, so I'll see you there. Yasmin, you're going there?
No, I'm not going.
Okay. Where are you located now, Yasmin?
I'm at Geelong Hospital.
Oh, Geelong, all the way down south.
Yeah.
Okay. Yeah.
Bit colder.
Yeah. But that's
Not as cold as here, though. Tasmania.
Yeah.
All right, I'll see you. Bye, everybody.
Yeah, that'll be lovely. Okay, thank you very much, everybody. And
thank you.
Best of luck with your submissions. And I'll see you in 2 weeks' time after, I think, the week after your second assessment. Okay.
Thank
Good
you.
night, everybody.
Bye-bye.